for being here after lunch, and hopefully we'll put you all to sleep. I am going to talk about, of course I had to change the title because I didn't know what that meant. So I said, considering opioid use disorder in patients with chronic pain. And I'm going to start out with a case that is similar to the cases that we've seen. This is sort of the case of the day. 55-year-old man, history of failed back surgery on high doses of opioids. Primary care physician recently retired. So an inherited case. Taking long-acting oxycodone. These are at high doses, and short-acting oxycodone. You look back at the chart, there aren't that many urine tests done, but a few were, and they were appropriate for oxycodone and nothing else. The prescription drug monitoring program showed no additional prescriptions. The patient had symptoms of depression, which are very common. He reported that his symptoms of depression were because of how much he hurt. And he was quite inactive. Physical therapy made it worse. So I think this is a pretty representative case we've had, and we've seen similar ones. Today I'm going to talk a little bit about opioid epidemic trends. We've seen some of those slides. A little bit about taking a history, pain history from patients who are on high doses of opioids, and then talking to patients about those high doses of opioids. When I say making an opioid use disorder diagnosis in these patients, I'm really talking about, in James' terminology, either an opioid use disorder or this complex opioid dependence. And then talking a little bit about switching to opioid use disorder medications. You can decide on the indication, and then treating a little bit on treating chronic pain. So the opioid epidemic, these are 2017 numbers of 1.7 million adults having a prescription opioid use disorder and 0.7 million heroin-involved opioid use disorder. This is clearly an underestimate because it doesn't include people in institutionalized folks, people in prison or jail. So this is not the right number, but it is a number that we use. And then of the 70,000 drug-caused deaths, 2/3 related to opioids. We've also noticed in the opioid epidemic and in HIV and hepatitis outbreaks, more in rural areas, more in young adults, related to the injection use of opioids. So the origins of the opioid epidemic, I think we've heard a lot about this in terms of how it happened. I would refer you to Greenland. I think Greenland is a good summary of both sides of the epidemic around pain management and then also around changes in the drug market and the heroin market and how that interacted with pain management to cause these problems, which are interdependent and have unique aspects individually. We've clearly seen some overprescribing and diversion, and I think that diversion among youth was a very important contributor to the problem. Heroin became much more widely available and cheaper, and then of course there's been chronically limited access to medication treatment for opioid use disorder. This is a slide I don't know if we've seen it today, but just showing the parallel trends of how much opioids were prescribed, death due to opioid overdose, and admissions for opioid addiction treatment. And then these are more data on prescription opioid-involved overdoses. This is Washington State data, and really the point here shows the increase through about 2010 or 12, and maybe a leveling off or maybe a slight reduction in opioid-involved, prescription opioid-involved overdoses in Washington State. I think that that's attributed to some of the practices that have been taken and some of the laws that have come about. Unfortunately, it hasn't translated, and this is a slide I think I've seen a couple of times today already, where you can see the rise in the blue line heroin, and then the even steeper rise in other synthetic opioids, that's fentanyl, overtaking even heroin-related overdose. So this is not about pain management, but it does show that the opioid epidemic in terms of true addiction, their addiction has really skyrocketed in terms of death and really is a national emergency that we need to find ways to deal with. So unlike, this is the contrast to some of what Jane said. This is a pain and addiction, some of the common threads. The American Society of Addiction Medicine is at a conference looking at the common threads between pain and addiction for a couple of decades. Some of the risk factors in neurobiology are similar, also some aspects are different. They both are chronic problems and they're recurrent. Treatment has similar elements in that they're chronic diseases that need medication, that need self-management, and need social support. I do really call out the patients on higher doses of opioids that are prescribed for those patients. They really are the opioid magnets. Those are the people with mental health and prior addiction who are really overrepresented in patients who are on higher doses of opioids. And really it's the high doses that have been shown to cause problems in terms of safety, and really these are all observational data, higher doses causing lots of problems or being associated with lots of problems. A lot less data is known about the lower dose patients who may be using opioids in a more functional way. So in terms of looking for a way to take a history on a patient who's coming in, that inherited patient, I'll refer back to really, and that's a lot of what my talk is about, is just talking to patients about these issues. Getting the pain story from the beginning is really important, and I use reflections there. Really, when I say that is a motivational interviewing strategy, and really what you're looking for. And for me, the big money when I'm hearing a patient's story is about how they've been treated in the medical setting. Because so commonly these folks feel like they've been treated very poorly, often they have been, and really trying to, if you're going to get on the side of the patient, you really have to demonstrate that you've heard them when they talk about the treatment that they've gotten and their dissatisfaction with it. So that's probably the pearl I look for the most, and I'll say, and if they don't bring it up, I will bring it up myself around how they've been treated in the past. I do look for these, the functional level, the pain-related goals we've heard a lot about today, and I'm looking for other kinds of conditions that might be connected to their opioid use. Sleep apnea, hypogonadism, depression, inactivity. These are common, and I may use them in conversation later as part of our discussion of their opioid medications. I also look for issues in their upbringing around adverse childhood experiences, and I find them a lot in the higher dose patients. I look for an addiction history, but I don't tend to focus that on the current or even recent past, but really looking back when addiction often develops in their adolescence, and whether that's alcohol or other drugs, I really want to understand their sense of that, as well as what the course of that has been. But I do find a lot of patients who are on high doses of opioids, even those without much in the way of aberrant behavior, who have this history of some kind of addiction in the past. And then I'm looking for what I call side effects. These are some of them obvious: constipation, but other things that might be related to depression, like symptoms, low energy, poor concentration, and then some things that are a lot more like addiction, or at least included in that definition. Thinking about opioids a lot, concerns about their addiction, maybe loss of control at times of their pain medication, and that other people might be worried about their use. So really trying to get a broad sense of where they're coming from before we make any kind of discussion around what to do. So raising the issue of what to do about the opioids, I like to start with something about what they've heard. Nowadays, everybody's heard about it, and often people even are resistant from that first, what have you heard about the risks oh, they don't apply to me might be the answer, but often people have heard, and you can get them to talk about it, and they do have concerns about the use of opioids because of what they've heard about their risks. I do try and emphasize that the problems that we encounter with opioids are problems that we didn't know about often when people started medication, and I think that's an important caveat for patients to understand and to accept that this might have been something that happened to them, not something that they did or intended. I do talk about the guidelines that suggest avoiding opioids for chronic pain more again to try and understand how the patient reacts to that. And I do try and emphasize my concern about possible safety problems or health problems over time. And those problems are not just about dying, although I am concerned about that. But some of the issues around loss of control can happen at any time. About mood, people don't necessarily connect their opioids to mood, although a substantial number of people do actually feel like their mood might be worsened by opioids. And then sexual satisfaction, pain sensitivity, or conversations you can have. I do emphasize that lower doses are safer, and many patients do well. I certainly had patients who were able to taper substantially and felt a lot better, even to the point of sort of waking up and feeling like, oh, wow, my life is a lot better and different, and I didn't realize where I was for those 20 years on opioids. So I do share that with patients and try and get them to understand that there's a lot of alternatives that might help. And these are medication or non-medication and self-management of their pain. And we have time. I think I'm a primary care doc. I also do addiction medicine, but I do it in a primary care setting, and just having time makes a lot of difference. The first conversation is not the second or the last. And I find that patients increasingly, as they become trusting in a relationship that's going to be ongoing and that they see concern, they start to think differently and to maybe think about doing things differently. Going slowly is something that I emphasize. Sometimes there are situations like an overdose event where you might not have that luxury, but often you do, because these are patients who've been on medicine for a long time. They've usually passed a bunch of tox screenings, and they've not had a lot of early refills. They are fitting into some nether region between pain and addiction that we may have not yet defined. Here are the diagnostic criteria for DSM-5, and I think it's interesting that DSM-5 came about kind of as opioids were escalating, and people were worried, well, gosh, maybe opioids a lot of opioids for chronic pain is maybe a good thing, and we should definitely not stigmatize them by calling them someone with a use disorder. That definitely is part of it. I think these criteria are, I take them with a light touch, but I'll point out a couple things that have helped me. One is the craving or urge to use is a DSM-5 criteria that wasn't there before. So how do you ask about that? I ask about, do you find yourself thinking about opioids a lot on a day-to-day basis? And I find that a lot of people do think about opioids a lot, and I'm just interested in that phenomenon. And then tolerance and withdrawal. These were specifically intended to exclude people who were prescribed opioids for pain, but really the criteria is that they need to be taking them as prescribed. And so finding ways to evaluate whether they are doing that, to me has been helpful. Because a lot of people aren't, and a lot of people sort of run out and they don't ask for early refill, but are having the experience with their opioids of coming on and off of them repeatedly, and I think their brain changes may be related to that. The key principles here, negative consequences, I'll talk more about that, craving, tolerance, and withdrawal, and you can see the severity, and that moderate to severe opioid use disorder is really what they used to call opioid dependence in DSM, and that's really those are the criteria that have been used in all the trials of addiction treatment, medications for opioid use disorder. So diagnosing opioid use disorder can be difficult in this population, and I think we've heard about a lot of the brain mechanisms that might make that difficult. The diagnostic criteria are certainly not connected in any way to the brain changes that we've heard about. 4 or more criteria constitutes a moderate to severe OUD diagnosis, and may mean that OUD medications could help. And then, really, I want to emphasize that OUD medications are really highly effective. There's not that much that we do in medicine that is as effective in keeping people alive as treating their opioid use disorder with medication. We're talking about reducing the risk of death by half or a little bit more with these medicines, and that is profound, especially that's observational data, just like the observational data that dose-dependent increase in prescribed opioids is associated with overdose and death. Here the observational data is the exact opposite. So I approach patients, are you concerned about addiction or loss of control of your medications, or have others been concerned? I find that some patients will react really defensively to a question like that, but many won't, especially if they felt like they've been heard in their pain history conversation. Do you sometimes have worse pain, take more medication, and go without later to make it up? This is quite common in folks who are on higher doses that I talk to. Have you wanted to try and cut down or quit? That's straight from the criteria. But I'm really interested in why. Is it just because, are they worried about safety? Are they worried about side effects? Are they worried about their family? What are they concerned about? Or how can I maybe use that to help us get to a plan? Do you find yourself thinking a lot about your pain medication? Is that a good question for craving? I don't know. I don't think anybody knows, but it seems to be common in my conversations. And then a couple of questions I'm keeping in my mind. Is the reduced function that's so common in folks on high doses of opioids, is that because of their pain, or is it because of the opioids, or the medication, or something in between? I just keep an open mind about that. Ask my patients to consider it. And then our side effects that you might have, or when I'm talking about that broad range of side effects, are they included in continued use in spite of consequences as a criteria for opioid use disorder? These are not definitive statements, but a lot of times the pattern emerges. The patient gets from these questions a sense that opioids might be the only thing they know and the only thing that helps, but also these other sides to them that might motivate them to consider a change. So the rationale for switching to opioid use disorder medication is primarily that the treatment for an opioid use disorder with buprenorphine or methadone is safer than high-dose opioids. We don't have a lot of data. I certainly will tell you, and I've talked to a lot of practitioners who have had similar experience, that when patients are able to transition from high doses of opioids, maybe taken as prescribed but not quite, where the up and down of their brain is happening with opioids on a daily or near daily basis, that they do quite well on buprenorphine for treatment, and their brain, the stabilization that happens that I see in frankly addicted patients can also happen in these patients who are treated with high doses of opioids. The side effects from opioids, especially sedation and withdrawal, are definitely reduced when patients are transitioned, and often patients' function can increase, and that stabilization of opioid systems, I do feel, helps patients focus on other aspects of their care in a way that they may not have in the past. So if they've been focused on defending or their opioid use and making sure that it's a stable supply or an increasing supply, they have less room for the other kinds of pain management that I think can be helpful. So, but I'm not an addict. I don't have a safety problem. This is resistance if you're thinking about motivational interviewing. I think it is important to acknowledge that this is something that they didn't control, but this may not be an issue that's like a standard addiction that we see in a street user of heroin. At the same time, this did happen to them, and they are in a situation that may not be safe. It's not about who they are, what happened. And actually, when I talk to my patients with frank addiction, I have a similar conversation. They all have lots of adverse childhood experiences. Their addiction didn't come out of nowhere. It wasn't a moral failing. It was something that happened to them over time. Many patients develop an opioid use disorder as a result of pain treatment. You may not agree with me on that one, but I do think it happens. You can review the criteria of DSM-5 and talk about it with your patient. Acknowledging the stigma of opioid use disorder as a diagnosis is important. There's also a lot of stigma when people show up, certainly in the medical system, on high doses of opioids. And in some ways that stigma is rivaling, in my mind, the stigma of an opioid use disorder diagnosis. And of course, people don't think that they're going to die of an overdose, but I've had patients do it. And the patients really think that they're going to stay on opioids a really long term. And I've had a number of patients who that question has prompted a discussion that's led to maybe reconsidering what's been going on. So who should switch to buprenorphine for an opioid? Well, again, are you switching because the pain medicine that they're on is not really helping them function that much? Or are you switching for an opioid use disorder? Well, I think you could look at it either way. In my practice, I see a lot of Medicaid patients. I can't write buprenorphine for pain, but I can write it for an opioid use disorder diagnosis. Maybe that helps me in one way or another. Should anyone with an opioid use disorder and they're not using their medication safely, should they switch to buprenorphine? Oh yes, in my mind, yes, especially high doses of opioids, because I don't think it's going to end up being safe for people on high doses who are not using their medication safely to somehow start doing a safe transition to low dose of opioids. I think they're going to transition to something that's even more chaotic. So those patients are at kind of the leading edge of yes, they should move to buprenorphine. What about patients with an opioid use disorder defined fairly broadly and chronic pain whose function has not improved on high doses? I would say again yes, that those patients are a good candidate. They may also be a candidate for a taper, although I'm going to watch carefully about that taper because I'm worried that it may or may not be safe and it may or may not help their function. What about patients who have an opioid use disorder diagnosis on just high doses, whether their function is improved or not? Should they be transitioned? I wonder. I think there's a good chance that buprenorphine will do as much for their pain as their other opioids, and that we should give it a try, knowing the safety benefits. And then any patient on high doses of opioids, high dose opioids, maybe we know that buprenorphine isn't approved for the treatment of pain by the FDA. It will never be because it's now generic. The studies won't be done. We will not have a label indication for chronic pain with buprenorphine. And then patients who are, and actually this is a pretty large group relative to the high dose folks, but patients getting a functional improvement with low doses of opioids. Should they move to buprenorphine? I don't think so. You're probably taking people who are not even physically dependent, not having withdrawal if they run out of their medicine. Maybe they don't do as much for a little while so they get some more. I doubt that. I doubt that we should be using buprenorphine in that group. So what about the question of tapering or switching? I think that there are a lot of patients where that can be part of the patient-centered care that we're trying to provide. What do they want to do in terms of trying to offer buprenorphine? I have to give them my experience that I have a lot of patients who medication and feel a lot better. So I need to share that with my patients. But a taper is a reasonable approach. And we know that we don't have good data about how fast to go. The 10% reduction as a one-time thing doesn't seem to cause withdrawal in my experience, but from there you really have to personalize. You might target a particular goal in terms of dosage initially, or maybe not, just to see if you can make it a little safer, or to me, maybe we can get rid of some of these side effects from your opioids. And then OUD diagnostic criteria, as you get to know someone, it might come up, it may become more obvious. Obviously, safety problems with opioids may need a more directed approach. And then I'll just, learning to treat chronic pain, we've heard some great talks about this. Educating patients that chronic pain is a disorder that's not well explained by tissue damage, to me is very important. Diagnosing and treating mental health issues improves pain outcome. There's lots of opioids that are non-opioids that can help, and the non-medication treatments are really, really key. I've had physical therapy failures come to me, and with some discussion with them and the therapist, be able to do much better. Above all, don't abandon your patients. These are really vulnerable people. They're at risk to die. They need your support. And I really think it's important for people to learn how to use buprenorphine so you don't have to be in the situation of a long-term relationship. And now you have to get a new one with somebody else you've never met. So you don't have to discontinue and refer. And make it clear that whatever the opioid plan is, that you're going to be with them in the long run. I think that's the most important primary care lesson. So this is just a summary. High doses of opioids for pain is not safe. Opioid use disorder treatment with buprenorphine or methadone is much safer. You can have conversations to discuss with your patient about DSM-5 criteria for opioid use disorder, but really the issues of weighing benefits and risks is an ongoing one. And then learn to treat opioid use disorder with buprenorphine and really don't forget to treat chronic pain effectively. And thank you for your time.